coming for sure.
Awesome work as always. We'll move on to our next speaker, Dr. Mirza. He's going to be talking to us about augmented reality as it relates to the microscope.
So, hello everyone. Can everybody hear me and see me?
Yes.
Okay. So, Mohammed, all participants, faculty, dear friends, thank you for inviting me. Good afternoon from Marburg, Germany. It's not going to be easy now to hold a good talk on augmented reality after this great presentation by Theresa, but I'm happy that it revolved more on instrumentation and less on these microscope applications. We started 6 years ago with this. So ICT was bought in our clinic in 2016, and we started with augmented reality in 2018. And we concentrated not only on cranial things, but also on spine things. And there are some maybe interesting things to show. My name is Mirza. I'm born and raised in Bosnia, but I worked in Germany for the past 11 years. And this is the city where I work in Marburg, just 100K north of Frankfurt. I show this every time because it's not very well known in the world. So these are one of the last publications from our department on augmented reality. So for acoustic neurinomas, for intradural spinal tumors, and prior, which are relevant for this webinar, intraoperative ICT-based navigation, augmented reality for lateral approaches, and for resection of herniated discs. So we use low-dose protocols with our intraoperative CT. They allow significant reduction of the ED, and the workflow is described in one of our first papers on augmented reality when we've implanted screws in the C2 fractures. It was published, I think, in 2019 as a technical note. And since then, we kind of developed several applications which are for operative microscope only. We use Kinevo from Zeiss. So what is augmented reality? A significant advance, which provides a real-time image overlay of three-dimensional structure, of segmented two-dimensional structures on the three-dimensional field in the intraoperative microscope. First papers came out in 2013, 2016, mostly as case reports and as proof of principle. When we first get the gadget, we were doing this. We took a model, we would do a CT of the model, then we would do a segmentation of a vertebra and of the nerves, and then we would create a three-dimensional image which was then reproduced in the operative microscope. So the workflow is that you put the patient, you position the patient on the table, you put the reference array on the patient, you do the intraoperative CT, and then you fuse the preoperative imaging with the preoperative imaging. You have the pre-segmented structures, and these pre-segmented structures of interest are then superimposed on the binoculars of your microscope. So this is our last publication on use of it in the lateral approaches for the spine. This was a resection of a herniated thoracic disc. The patient is positioned on the lateral decubitus side. You do the X-ray for the level localization. You go laterally onto the spine, and after that, you usually put the reference array proximally to the field. We do not attach it to the pelvis. We just kind of taped it proximally to the operative field, and then we do the intraoperative scan. Now you have the preoperative images where you can segment the vertebrae and the herniated disc and the spinal cord, the dural sac, or whatever structure of interest you have. And then you can fuse these pictures with elastic and with rigid fusion with the intraoperative imaging. And then you get, when it goes to your microscope, a real-time image of the structures which you are operating. You can check the navigation accuracy. And again, the question of Francesco right now was navigation or augmented reality. I would say both. You know, there is no good augmented reality if you do not have a very high accuracy of navigation. And as for the question, in which cases do we use it? We used it in the beginning in almost all cases because, in our opinion, it's good when you have a new technology to try it out on a very simple and straightforward case. And in that way, then you can use it properly in a very challenging case. So this is an image which you get following the exposure of the lateral spine via the lateral approach, or transpleural or retropleural. So you see here that the patient is on his right decubital position. You are standing behind the patient, and this is what you look through the microscope. You see the two segmented vertebrae, and between them you see in blue, in the upper pictures in red, in the under pictures in blue, segmentation of the herniated disc. And this is especially interesting in cases when you have a calcification of the disc, because when you expose the lateral side of the spine, you usually see just a big bone chunk, and you don't see any intervertebral discs, and you need to orient yourself, which is, in my opinion, not very easy with X-ray and with navigation too. There are other applications. For example, when you put an implant there, if you're doing a corpectomy and then you do the control CT, you can also do stuff like do the segmentation with auto segmentation, manual segmentation of the implant, and produce very nice pictures like this, which can then show you more intuitively, is your implant well implanted. And there is also a video to show this, very short, just for the viewers to get to get a sense and feeling how does this look. So this was the case. Patient was operated in a previous clinic. And this is the preoperative CT, which shows a calcified disc. These are now the intraoperative images with the segmentation following surgery. And this is a very crucial thing. This is what you see when you start to use your microscope. Now you see here two vertebrae. In yellow, you see the herniated disc in blue. And in that way, by adjusting the zoom or the focus of your microscope, you can always watch on the head-up displays, which are not on your microscope, but next to in your OR. You can always know where are you during the surgery, at which point of surgery are you at that very moment. So this is how it looks. You operate, you do your drilling out, and you have these outlines all the time present. And in every moment of the surgery, you know exactly where you are. Now, for older generation of surgeons to have these outlines all the time is, they get usually upset. Not my boss, but a lot of them. And there is a possibility to shut off these lines, to take it off, but you can still watch them on the head-up display, which is in the same OR as you. This was a very rewarding case because the patient profited a lot, and this is somewhat the end result. So you see that this is a three-dimensional reconstruction of the herniated disc, and it is exactly there where you would expected it to be, or where it actually was. And this is the intraoperative image following this is also a case of a herniated disc. You have here a segmented herniated disc in yellow. You have the dural sac in green. This is the fusion of the preoperative and postoperative imaging. You see here the retractor for the ITSLIP approach. You do the fusion, which is in spine, also very challenging. You need to have elastic and rigid fusion. This is the calibration of the microscope. This is throughout the surgery, and this is the end of the surgery, where you see that the spinal cord has gone back to its place, and that the posterior third of the vertebral bodies of two adjacent vertebrae and the herniated disc are drilled out. And in this side, you see on the left side the preoperative, on the right side the intraoperative imaging, which shows the complete resection of the herniated disc. This was the herniated disc plus ossification of the posterior ligament. And this is the same patient with preoperative and postoperative imaging. And this is also one image from one of our publications, which shows the augmented outlines. We do change the color a bit, so sometimes dural sac is green, sometimes dural sac is red. It's not very intuitive always, but I think it explains the point very well. You can use it also for tailored corpectomies. In some cases, especially if you have a tumor case, sometimes it's very challenging to do a proper corpectomy and to place your vertebral implant. And ICT, although the cost of it is very high, especially if you're a low or in middle income country, it's not for Germany, for UK, or for the States, but for low and middle income countries, there is a significant cost to it. But it has a several very good sides. It has zero exposure for the personnel, for people who do the surgery. It has a very low exposure for patients, and it enables you automatic registration for the patient for the correct navigation and immediate intraoperative control. You can use it also in posterior surgery. You can use it for screws, as we heard in the talk before. You can use it for navigated placement of cages. This is another case, and this was published recently in World Neurosurgery. So the group from Marburg and the group of Roger Hertel from New York were the first group which published experience on intradural augmented reality in intradural spine surgery. And this is one of our studies with around 40 or 50 patients who were operated in this technique. So this was a patient who underwent a resection of ependymoma. We first did a stabilization of the cervical spine because we did a 4-level laminectomy in order to get the ependymoma out, and to prevent the post-laminectomy kyphosis, we performed the stabilization surgery. And following the stabilization surgery, we did an intraoperative scan to control the implants, and we did the segmentation of all the implants and all the structures of interest in order to improve the orientation in the intraoperative field. Now, this case is a case where you don't actually need augmented reality because it's a straightforward surgery. You have microsurgical principles, but there are many cases where you have tumors where you need to get them completely out, and they have very tricky relations to important neurovascular structures. You have tumors which go around vertebral artery. You have end block spondylectomies where you have a tumor which has a very tricky relations to all kinds of structures which you can segment in the preoperative imaging and superimpose in your augmented reality. So this would be the calibration of the microscope. So like I said, in this case, the reference area was put on the Mayfield clamp. The head was in the Mayfield clamp, but we usually tape it proximal to the field. And we did have also in that way a very, very high accuracy. But I would not do it for screw implantation. But for microscope-based resections, tailored resection, I think the accuracy which you get is enough. So you have here the outlines of all the screws. You have outlines of all the vertebrae. You have outlines of the tumors and of the spinal cord. And like I said, this is not the case where it is decisive to have this kind of surgery, but it shows very nicely what is augmented reality capable of. You see here the screws on the sides, how they are oriented. You see at every time where the tumor is. And what's also very interesting, and that was shown by Hertel and his group, when you open up the dura and you release the CSF, you virtually don't have any shift. And that is very interesting because in brain, when you let the CSF out, you have a major brain shift and the navigation goes wild. So like I said, we use this in straightforward cases in order to use it properly in hard cases. For example, in this case, this is a recurrent neurinoma of vertebra in the L5 on the right side with bony erosion of the vertebra. These are the preoperative images. The patient had a surgery some 15 years ago. The neurema came again, the paresis, they needed to get done. So we've opened up the cetus, we've presented the scar tissue, and then we did the intraoperative CT and superimposed the preoperatively segmented structures on our intraoperative microscope. We also did the navigation update on the bony edges. And on this photo, on the upper side, on the left, you see all of the structures we have segmented. We have segmented the tumor with green, the tumor cyst with yellow, the dural sac in purple, the vertebra is in purple and dural sac in blue, and this is all superimposed in real time on your operative microscope. So this is the way we found very easily the dural sac, opened it, and this is the kind of image which you then get when you look through your microscope. You have actually with very high accuracy, you see the tumor, you see where the tumor cyst should be, and you see all other important relations to it. And this is how it looks under the operative microscope. And like I said, in cases like this, in cases where you have a tumor which is encasing very important neurovascular structures, I think this technology has future apart from producing very nice images which you can then show on a congress. And what we also done, and with that I'm going to conclude, is we have also put a 3D navigated ultrasound into the scheme. So you do a 3D scan and you fuse it with the navigation, and then you also have images like this where you do ultrasound scan on your operative field, and you get the segmented outlines also, which is also then very good because ultrasound is the only really immediate intraoperative.
So Dr. Mirza maybe have some problem. We'll give it, why don't we